Dear colleagues, let me introduce the following case. Today we are talking about alcohol septal ablation. Uh, just a moment, just a brief talk about the history, and you know that the first procedure was done in 1995 by Ulrich Ziegwart, and the concept is drawn on this picture. And you should realize that um, we during this procedure we injecting alcohol, small amount of alcohol in the septal branch, and it causes necrosis in the basal septum, and after that it became thinner, and it precludes following obstruction, and helps to remove obstruction completely. Uh, let's talk about the case. He was 62 years old, and he is male, of course, and admitted with complaints on dyspnea. Uh, he has anamnesis of heart failure symptoms since 2015, and Minoka in the previous year, and it was associated with chest pain, with elevation of ST segment, but with completely undiseased coronary arteries on the angiogram. So previous angiogram uh, from from September of 2020 showed completely healthy arteries with no obstructive coronary plaques. And at this moment, ECG seems normal with sinus rhythm and some kind of signs of hypertrophy. On echo, we observed um, LVOT obstruction with a resting gradient of uh, 33 millimeters mercury and 77 millimeters mercury after exertion. I mean, generally we use physical exertion, 20 sit-ups, not the pharmacological provocation, because Valsalva pharmacological provocation in our experience was not so effective for as a provocative agent. Uh, IVS, interventricular septum in the basal segments, was 16 to 70 millimeters depending on the projection. Parasternal was 16, and 17 was in 5-chamber view at the level of mitral septum contact. And as well, moderate MR was present, and on the pictures on the right, you can see that on the 5-chamber view, you can see 4th-chamber or 5th-chamber view, probably you can see 70 millimeters of thickness of the basal septum, and you can see the long anterior leaflet 31. Generally, we always consider that long leaflets can lead to not so effective ablation, or not so effective just removal of the septum, and maybe some kind of mitral shortening, mitral leaflet shortening is needed if you talk about surgery. But in this case, we consider that this obstruction was not so uh, is what this patient not so eligible for surgery due to age first. Second, he was truly obese patient, and we decided to perform ablation first. Uh, of course, we calculated a risk of sudden death. Just below you can see it was 1.7%. So we concluded that this patient had a low risk of sudden cardiac death, so ICD or implantable cardioverter defibrillator is not indicated. This procedure and how it looks like, you can see in the apex of the right ventricle. We placed electrode for temporary pacing, and we placed pigtail catheter in the left ventricle um, to um, to for hemodynamic assessment, for measurement of LVOT gradient. And as well, we used 6 French, or in this case 7 French guide, EBU 3.5. Generally we use launcher for these purposes, and you can observe that maybe 3 to 5 perforators in the basal septum you can observe, but the one was the largest one. And after several attempts, we were able to cannulate that with hydrophilic wire. It was filter wire with OTW 1.5 mini track balloon, and this is a basal intraoperative echo, and you can see that LVOT tract, how it looks like. And after the injection of contrast, generally we are using 4% gilofusine for agitated gilofusine for these purposes. It's a perfect agent, I believe, and it helps us to delineate the zone of further ablation. And you can see how it looks like. And we in this patient we bump into just LVOT vascular bed supplying from this target perforator, and that's why we decided to ablate it. And this is the injection of the ethanol, and after injection we are trying to flush it with the contrast to be able to ensure that all our ethanol is leaving the OTW balloon shaft. And after remove the balloon, this picture looks like the looks like as follows. And you can see that our perforator is closed, and you can see kind of impaired flow in the second septal branch. And generally we are doing the exposition for 5 minutes after the injection of ethanol. Our balloon inflated, and we are just waiting for 5 minutes, and after that we are deflating the balloon and check the patency of the branch and check our hemodynamic result. This patient, it was like that, and you can see the basal parameters of the hemodynamics, and you can see the resting obstruction of 70 millimeters mercury. You can see it really depended on the rhythm. We have a lot of extra systoles, and which unmasking the obstruction, and you can see how it looks like. And after ablation, we needed just pacing to see kind of obstruction. You can see that for in resting settings it was like zero gradient between left ventricle and aorta, and after pacing you can see that the peak gradient was about 15 millimeters mercury. This patient was his clinical course was perfect, was good, and uncomplicated. But after a week after ablation, COVID-19 infection was diagnosed, and he was discharged, and he was hospitalized in the COVID hospital. As always in our life, it's not always perfect, and but we checked his. I call him, and he's really perfect, and he's without symptoms at this moment, and I'm waiting him for the follow-up, 3 months follow-up. Generally, we follow up our patient at 3 months and 1 year after procedure. And this patient, it seems that this procedure was perfectly done. Two main borderline indications was that this septum was really seen. I mean that 7 millimeters of basal septum is sometimes it is very difficult to decide to do or not because of the risk of the perforation, and long leaflets as well can lead to insufficient effect, but this patient was perfectly response for our procedure, and you can see kind of selection criteria for alcohol septal ablation. And first of all, our patient should be truly symptomatic with 3 or 4 functional class, New York Heart Association functional class. Generally, for alcohol septal ablation, we are trying to select patient with just LVOT obstruction. You know that sometimes mid-ventricular obstruction can be observed in some patients, but in this kind of patient, this ablation is not so effective, and generally in our practice, mid-ventricular cases is an indication for surgery. Appropriate septals, it is very interesting one, because it is very rare thing when we don't have appropriate perforators. For example, if we have a previously implanted stent in the proximal segment of LAD, but generally in most cases I realize that most of the sepals are appropriate, even if they're less than 1 millimeters in diameter. Absence of mitral disease, of course, if you have internal disease of mitral valve with a central regurgitation jet, it is not this patient is not a candidate for alcohol septal ablation. And if we observe SEM-related MR, I mean systolic anterior motion related mitral regurgitation, generally it's okay, because after septal reduction, the systolic anterior motion is decreasing, and as well mitral regurgitation can be reduced, might be reduced in maybe more than 60%, I believe. Subvalvular mitral anomalies, in most cases we are not taking into account this fact, and you can see a very difficult case. This person underwent alcohol septal ablation, myectomy, and he's still suffering from the obstruction with 80 millimeters mercury gradient because of the long 45 millimeters long leaflet, anterior leaflet, with this kind of movement, and it seems that this obstruction cannot be removed without the replacement of the mitral valve, I think. Appropriate septal thickness, we just I just mentioned about this. 70 millimeters and higher generally is considered to be appropriate for ablation. If you talk about the 30 and higher, of course, in these cases, however, ablation may be less effective than surgery, but we can discuss about this, and it depends on the patient conditions, and maybe in some patients we can choose this kind of septal reduction as well. LBB, left bundle branch block. Of course, we should discuss with patient if preoperatively we observed LBB, and we should discuss with patients that we can ablation leads generally to RBBB, I mean right bundle branch block, and in this instance it can lead to complete heart block and pacemaker implantation. If patients is agreed with this kind of in this kind of intervention, of course there are drawbacks of implantation of the pacemaker. We should check it every year, and some kind of infections can be observed in some patients, and higher rates of hospitalization for decompensation of heart failure. But generally, it was shown that after alcohol septal ablation, implantation of pacemaker does not leads to higher mortality, and it seems to be okay in most patients if we have such kind of issues. But we should discuss. LBB generally is a good indication for surgery as well, but if patients diseased and have a lot of comorbidities, we should perform alcohol septal ablation in most cases. And younger age, of course, nobody wants to deal with infarction in younger patients, but in some cases it as well possible to do, and we have some data related with that it's not inferior to surgery in terms of mortality. Of course, we don't have a lot of data regarding the arrhythmic risk of this kind of patients, and younger patients have predisposition for sudden cardiac death, and we should selectively implant them cardiovascular defibrillator and discuss the further intervention related with LVOT obstruction as well. So this was all points which I wanted to discuss with you. I think that this case was truly interesting because of some facts. First, this procedure can be done in very not so thick septum with long leaflets. It is also okay, and we move our procedure from the position of the alternative procedure for the first line procedure. I think that the endovascular approach is a preferred approach in most cases, but of course in some cases surgery is better. In my practice, most of the patients have a higher age and a lot of comorbidities, and my preference is to do ablation, but I'm trying to select most appropriate candidates for this kind of procedure, and select as well for surgery patients who can benefit from this kind of intervention. Thank you very much.